I have an interview with another television broadcasting crew uh, at 9. So I gotta be out. Let's see. 9. Okay, who wants to go first? Who has to leave soon?
I think Juhi, maybe
Yeah,
the first.
Jui, do you want to go first?
I was just gonna listen in. I don't really have much updates. I'm just working on Albert Curie's case report at the moment. Um, Cancer screening. Zuni has helped write the introduction. Richard has helped write the methods, but I have to go read through everything. This week I'm gonna try to do the meta-analysis with Eugene. Finish it up this week. And then hopefully finish writing the results up to this week too. But yeah, I have been traveling back to Korea. I haven't really done much yet.
Sure. That is fine. That is fine. Thank you, Chuhee. We have Seungmi. Is Seungmi here? No? Maybe not. Okay. Richard, do you have any update? Let me know what you've been doing.
Yeah, so I've been helping Juhi with a systematic review. I had an article that I read through and did the bias screening and everything for it. And then I wrote the methods section too.
Huh?
I don't know if I should show it right now because we haven't gone through it or anything, but
Yeah. Go through it with Chui first and
Mhm.
show me the final version when you guys are done.
Okay.
Yeah, but I'm sure this will be a nice learning experience for you.
Yeah. Yeah, I've never written anything like this, so it was wow, yeah, very fun to learn about, I guess. Yeah.
Good. Oh, are you planning to shadow in clinic too, or no?
Yeah, so the thing is I'm going home tomorrow. Oh, actually no,
Oh,
sorry, tonight for a while. So it's been kind of hard because I've been pushing my flight around a lot,
hmm.
but I think at the end of June perhaps I'll reach out to I think Liam for that.
Yeah, that's totally fine. Yeah, but feel free to join us through the web and
Mhm.
yeah, yes, we're welcome. You're welcome to work with us in any format and anytime you want. Okay,
Thank you. Yeah.
great. Leah, Liam, are you able to give us update? Liam, no? He's trying to connect. Okay, Arnie, can you give us update?
Can you hear me?
Yeah.
Oh, okay. So, okay, I will give you a little bit update for me. Actually, Juni told me that he will online today, but maybe she's busy because she's contacting me yesterday. Okay, so I will share my screen today. So basically, for the hyper progressions, I'm being honest. I try to collect all the data as much as I can for the PDL1 and the very start data. Uh, I already uh, I already finished half of it, and uh, in the after did it for almost 1 or 2 days. I believe in 2 days, I think I can finishing the 140 patients for the PDL1 and the very start. Uh, for the very start data, mostly they don't have the data. Like I already did it until 70. It's maybe only 50% that have the very start. Like most of them is not available. I already tried to find in the media tab and anything. It's still. I cannot find it. Also, I have one thing that I want to discuss with you. Like this kind of one of the patients, the PDL1 shows like negative in tumor cells in the tumor cells and show very rare positive staining in the tumor infiltrating immune cells. So it means like how we put the in-house PDL1 is like negative or positive because the tumor cells will be 0, but the immune cell is less than 5. It's only one case that I found this in the table in the data, and I will ask you for your perspective about
Yeah.
this patient.
So in lung cancer, we look at tumor cell for pembrolizumab.
Mhm.
So I think for PDL1 level, you could just record PDL1 on tumor cell.
So which mean like it will be like negative even like they have the positive immune cell. Okay, I can.
Right, right. Just PDL1. So in your method, you just write PDL1 expression by immunohistochemistry
Mhm.
on tumor cell. Just make that clear.
Okay, I will make it like that. I think for the hyperprogression and for the incident last time like Eugene already counted for the 122, and also I also have one more patient about my data also, because last time we have 140 patients and 18 have some error because I told you they have like tumor error a little bit. They have like a same tumor burden or they have the same date, so we cannot count the TGK or the TGR. I already rechecked the data again into Epic. uh so the date I already correct it, and the calculation is can be proceed. But there's some patient that have like exactly tumor burden size for the pre-baseline and the baseline, and it will cause like a little bit error for the TGK ratio. So my question is like, do you want us to exclude the patient that have the same tumor burden or still put it in the data? Because for some hyperprogression definition, we cannot include this data because we cannot count the TGK ratio.
So are you saying we cannot calculate TGK because of incomplete data?
Not incomplete data. So basically, they have the same tumor size for the pre-baseline and the baseline. So as you can see in this table, like for
Are
the
you sharing your screen? I don't see
oh
anything.
yeah, I'm sure. Sure. Okay. Okay. This one, like this data, you can see like I already correct the 18 patients that have the same date or same tumor size. I check it in the Epic over and over again for last week, and for the date I can correct it, but for the same tumor size, there's some patient like exactly have the same tumor size, and we cannot count the TGK or ratio, like it's error in here. So basically, it cannot be this data for the one have the same tumor burden size. We cannot count their hyperprogression for some definition. We have 5 definitions, right? But some of it like we cannot count it. Do you think that we need still to include the one have the same tumor size or not?
So TGR you can calculate?
Mm,
Is it just TGK?
TGK and TGK ratio and TGR ratio. We cannot count it because they have same number.
I see.
But it's only like less than 15 or less than 12. It's like only 1, 2, 3, 7. It's only 8 patients that have the same tumor burden size. It's usually in the pre-baseline or in the baseline.
Okay, show me the post treatment numbers. Let me see how the numbers change.
Uh,
So it's
okay, wait. As an example, this one like 37, 37, 36, or like 43, 43, 48. It's basically a stable disease, but we cannot count the ratio.
I see. I see. Uh, so I think you, so these are not, well, I guess none of them are hyperprogression.
Yeah, usually it's stable disease.
Uh, for 58, it is still stable disease, okay.
Yeah.
So just say was in your method, you can say these 3 patients you were not able to calculate TGR, TGK ratio due to no change in between baseline and pre-baseline.
Okay.
So I don't want you to take these patients out of your
Data.
denominator.
Okay.
So you still include them
Mm-hmm.
as a denominator.
Mm-hmm.
Yeah.
Okay. So for all of that, we have 141 patients with the some 8 patients excluded because the calculation.
Yeah, just say, yeah, the non-available.
Okay. Mhm.
Don't say error, not, yeah.
Thank you, Doc. And I have another question for the data for the how is like the very for the very start data because it's mostly like not available. How we can gather the data? So because like most of the very start is not available. I already checked it. If the PDL1 we still have some hope, like almost 60% or like 50% like have the data, but for the very start it's really less.
So VeriStrat, do not do multivariate, just still with that, just do one univariate. That's all you need to do for VeriStrat. Don't do any multivariate, don't add VeriStrat with other factors.
Oh, okay.
And you checked everyone?
Yeah, I'm the one who checking everyone. I think I can finish it by today for the very start and the in-house PDL1. I
So
can finish.
Eugene, did you email Biodesics? So some Biodesics may not be scanned in the Epic.
Okay.
So we have to ask VeriStrat people, Biodesics people.
Yes.
Do you
So
remember I told you?
right. You told me, I remember, but we try to like cover up by ourselves first. So, but I will send them the email today.
Yeah, so the ones that we don't have, just put their, I don't know, name and date of birth.
And
And,
ask them.
and then put that in a Excel file
Mm-hmm.
and then make it password protected.
Okay.
And you can make the password VeriStrat or something.
Mm-hmm.
And send to them, can you
Check this.
let us know if these patients have done VeriStrat? If so, let us know what the result is
Mm-hmm.
and just CC me.
Okay.
Yeah, just to make sure we're not missing anybody.
Okay.
Okay, for the patient, lastly, like last time you asked us to do the histogram, right, for 140 patients. Juni already kind of make the sample. I think Juni can expand it more about this. This is the
Okay.
program that she made. You are being muted, Juni.
Junie, you can let us know.
So in the y-axis, like these are different criterias that we are using. X-axis, the different definitions that we are using, and on y-axis is the percentage. So according to the percentage, this is the rate of like percentage of hyperprogression we got according to the different definitions.
Did you put it in chronological order or was there a reason?
I just tried putting them in chronological order, but not any specific reason.
Okay.
I can make the bars closer, or if any
Yeah.
changes.
Yeah, you can make the bars a little bit closer. Et al can be italic.
Mhm.
I think you can make it by highest to the lowest in order.
Oh, okay, sure.
That's better. Wow, 48% is really high.
Yes.
Did you see 48% in any other literature, Arnie or Junie?
So basically, why it's 48%? Because I think because SADA doesn't have put many criteria for the definition. It's only like TGK minus the experiment for the TGK reference for 2. He didn't include resist progression. He didn't include like the other have resist, right? But only his definition, the simple one. When you have like less criteria, it will be like more incidents, right? So I think that's one kind of the reason. And maybe we can talk about it in our abstract also a little bit later. I think that's one of my thoughts, but yeah.
Okay, so Arnie and Zui, you will both work on this project. I think Yuno is leaving for Hawaii. So I don't think Yuno will be able to do anything more for this project. So you two are still the project lead for this. And Yuno will, before submission, he'll still be available to answer your question, but I don't think he'll be able to write it together with you. So anyway, I want you to write in the discussion that the Sada-Bouzid method is like, it's not practical because it doesn't have the resist criteria. Because resist criteria makes clinical progression meaningful. You could have 2 times more, but if it grew 0.5 centimeter, and now it's growing 1.1 centimeter, it's still more than 2 times the growth rate. And would you call that clinically meaningful? No. That to me is not clinically meaningful at all. So it might be hyperprogression by Sada-Bouzid definition, but it's really not relevant in clinical practice. So we recommend not using Sada-Bouzid method. Okay, that's what we're gonna say in our discussion. I think that's a fair discussion.
Okay.
Okay, just remember that point.
I write it in notes.
Okay,
So basically for this week, I will try to finishing all extraction the data from my own abstract and Zuni. Also, filling some of Yunho's data that kind of missing in his paper. So maybe like later, like Eugene can help us analyzing the data. And I really hope that by the end of this week or like earlier this week that we can start writing our abstract and finishing like Yunho discussion. I hope so. Like so, I will try to extract the data as much as I can for like the past 1 or 2 days. I think that's all I can say for our progress for our project.
okay. Is Eugene O helping you with the analysis?
Mhm. Yeah, she will help me, especially for Yunho data because there's many like missing have missing information. So yeah, I need to like cover it little by little. But Eugene helped me with analyzing all the data.
Okay, very good.
Thank you so much.
Okay, yeah. Okay, Liam, do you have any updates?
Hi, one moment. Not necessarily. We have two meetings today regarding the well, we have a meeting with the Reds program director regarding the transfusion project. We discussed last week that it's probably not going to be feasible at this point, but we still have that meeting set up for later today at 2 p.m. I believe. So I think it'll be good to still have that conversation and just kind of have that discussion and kind of get their input, what their thoughts are, and if they have any suggestions. And then we have one more biomarker study meeting at 3 p.m. I believe. And that's pretty much it. So the undergrad students right now, it's their finals weeks.
Hmm.
Their exams started this week and it'll run through next week. And then the following, so next Sunday is their graduation. So everybody's kind of busy right now. But we are wrapping up, but everybody said they'll be able to wrap up their videos once they finish their exams. So for example, Eileen finishes her exam on Monday and she said she'll be able to finish everything else.
What is she working on?
So Eileen has Marissa's videos.
Okay,
And Sally is going to be able to, Sally's coming in today in the afternoon to interview Melissa.
okay,
And yeah, and then Grace is going to finish Zuni's interview video as well.
okay. Okay, now, yeah. I think we have, we have one more undergrad. His name is Timothy Hong. So I want you to have an interview with him.
Okay.
Okay.
Oh, and then also updates on, I'll quickly share my screen. So as you mentioned, I reached out to Drexler
Yeah,
about the liquid biopsy
yeah.
submission. So she responded to me, very quickly. So saying she was away on vacation, so she wasn't able to submit it.
Uh-huh.
And she said she was going to submit the day after, which she tried to follow up with. But then there was a required section in the statistical analysis that was not in the draft. So her email, she sent another email with everybody, regarded, and specifically Dr. Davis, because Dr. Davis was the one who did the analyzing, I believe. So we're just waiting for them to get back to us with that information.
Statistical tests use. Okay, why don't, so this paper is, I send you the, yeah, let's talk about, because I think all these things are described in the paper. Mean media, confidence interval. I have to look at the paper to see what it shows. So let's take a look at the paper together after this lab meeting.
Okay. We can
Okay.
definitely do that. And then,
Why
Uh,
don't you print the paper for me and then we'll go through all the parts together and see what needs to be done. Okay, I think I forwarded that paper to you.
sure.
Yeah.
Yeah, we can definitely do that. And then for the addendum to the depository for the lung transplant,
Uh-huh.
I emailed Mary just asking if we can just kind of keep this structure and just kind of increase the limits and just kind of
Uh-huh.
keep it vague until we get final confirmation from our collaborating labs.
Uh-huh.
So we'll see what they say. I mean, I think that should work. And there's really no other way. So we'll do that. And then, so regarding the lung transplant programs or centers here at
Yeah.
Northwestern, so I did some research on how kind of the organization structures their transplants, and they have what's called the Northwestern Medicine Organ Transplant Center.
Uh-huh.
And this is the center that oversees all transplants, apparently. And the director for that is Dr. Satish Nadik. He is the professor of surgical research and chief of organ transplantation here at Northwestern. So I wonder if it might be best for us and more likely you to reach out to him and set up a meeting and proceed that way. I wanted to see what your thoughts were.
Yeah, because if he's the like the one in charge,
Yeah.
definitely. Let's draft the email
Uh-huh.
together and yeah, let's send it out today. Let's
Okay.
say something about, this is the program we're considering. This is, and then maybe attach a PowerPoint that we've used to send out to companies. The concept is there is definitely a cancer cell transmission happening, and what is our best way to screen now that we have a technology to screen. I think I think it still makes sense to still do ctDNA and maybe circulating tumor cell if there's a funding for it. Yeah, let's still ask, but let's prepare a PowerPoint. Let's draft an email.
Okay.
Show it to me and we'll send it together after like this afternoon.
Okay. And then, so in the PowerPoint, you want the content to be
More like explaining the epidemiology of contamination theory.
right. So it'll be similar to the lung.
The ones we've been sending out to companies.
Right. So it's going to be a similar logic to the biomarker study proposal, right?
Yeah.
Okay. Sounds good.
Yeah.
Okay. And I think that's it for me for now.
Okay. Great. Eugene?
For me, today I wanna have a second look at Curie's case report because last week we submit the Vivian's case report to JCOPO, and our team goal is to wrap up Curie's case report within this week. So because of your help, like we already we have several times discussed about the discussion part. So
Yeah. So there's surgeons involved, so we have to send to surgeons.
yeah, when we have a draft, right?
Yeah. So anytime you submit, at least once a week, go to the website of that journal and see, because they send back and say, oh, change the font to the size. They'll tell you what to do. So that's why you have to read everything in detail and follow the guideline. If you don't, they'll send it right back to you. Say, oh, this does not meet our guideline.
Okay. Okay, so for the
So
curious,
that email usually gets sent to me, but it sometimes goes to, junk mail. It's automatic reply or something. So that's why we still need to go back and see what they have sent.
okay.
Yeah. Okay.
Yeah, for curious case report, I think because we are almost close to 9 a.m. I think it's better for you to have a look at after your meeting, right?
Yeah, let's do that. So
Yeah,
I'll come back. This is gonna be 9 o'clock soon. Yeah, I'll be back at like, maybe we can start at 10 o'clock. Yeah,
again.
I'll be back in 10 for those who's still available. I will see you guys at 10.
Okay. Cool. Thank you.
Thank
My screen.
Mhm.
Mhm. So, so our target genre is closed medicine. They don't have any word limitation. They only require us to make the format abstract, introduction, something like that. So I made it into that format. And would it be okay to just me to point out the changes that I've made so far, or
Yeah.
okay. So for introduction, I made it into 3 parts, like introduction of his disease in IMA, and then I briefly talked about MRD here. So can you read this red part which I added? So here I noted which assay we used, but do you think it's okay to put the exact name, or can I just go by with the tumor informed or plasma only?
Yeah, I like plasma only. Well, plasma only, you can take out the based.
Oh, yes. Or I can also take out tumor agnostic MRD assay. I just found it in the another article referring Guardant, but I think plasma only.
Agnostic is fine.
Okay.
Yeah, I like the fact that you guys came up with plasma only. Yeah.
Yeah, actually there is an official term to refer Guardant.
Good. I like it. So Richard, this is educational for you. So I want this to be a teachable moment where if you only work with a tumor tissue-based DNA and you track that, then you're only going to be able to pick up what's tumor related, recurrence-wise. But then if you're just sequencing everything in the blood, you can detect myelodysplastic syndrome, you can detect, let's say colon polyp secretes DNA with APC gene mutation, then you can detect that. And you're wondering, did it come from lung cancer? Is lung cancer recurring, or where is it coming from? You have no idea. But it's good that you're capturing everything. So that's why we have 2 different assays done for this patient. Okay.
So here, the very last part of introduction, I try to emphasize the uniqueness of our case report. It's the first case that utilized cardiopulmonary bypass to minimize intraoperative contamination in double lung transplantation. And
so when you say contamination, people think about an infection.
Oh.
So you have to say contamination from donor circulating tumor cell or something.
To be more specific, okay.
Utilized in double lung.
Um,
Yeah.
And also I added, like, in addition to the except, do you think, can I call it like exceptional results of bolts for IMA, or?
No,
He's been,
exception is such a strong word to use
so,
for scientific literature.
okay,
In addition to exceptional, I would say positive is a rather
mhm,
neutral word. Positive.
okay. So because we deal with a lot about MRDSAs in our discussions, so I try to give a hint that our case outlines the application of MRDSAs in monitoring recurrence after transplantation. And currently, the patient remains stable with no evidence of disease, recurrence, or organ rejection in surveillance scans, CT, DNA assay, biopsies
Surveillance
over.
scans, he did undergo EBUS. Surveillance scan and
Oh, and biopsies. And
and yeah, and
maybe
and
would be better.
bronchial biopsy.
Okay.
He
Yeah.
don't, yeah, and yeah.
A serial bronchial. Yeah, he did underwent that. Okay. Yeah, it's been over 8 months, which is great news for the Curie, but at
Oh,
the
you
same
have
time.
biopsies here too.
Oh yeah, I already denoted. Okay.
So just put bronchial there.
Okay.
Yeah. Yeah.
Cool.
It's 8 months.
Yeah,
now?
it's been 8 months now.
Okay.
So in the case presentation part, I just reorganized the information using the plasma only ctDNA, like some terms, using specific terms. And other than that, not much are different from the previous one.
Okay.
And mostly I want to have a second look at discussion part.
Okay.
So as you gave us comment last week, I try to organize the paragraphs into more understandable way. Like, so for discussion, for the first paragraph, oh, still exceptional is too strong, so I will make it into positive, maybe.
Well, who demonstrated clinical response? No, I mean, this is not where you see tumor shrink.
Mm,
Under with no evidence, just say who demonstrated, instead of who demonstrated, just with no evidence of recurrence.
okay.
Or no evidence of disease. Let's just say disease, because disease is gone.
True.
Yeah,
And
that's enough. Yeah.
okay, it's enough. And then I try to write out why it's important to use bilateral bolt combined with cardiopulmonary bypass. So our team has previously utilized this technique in lung T for COVID-19 due to high incidence on their problem, and with our expertise in this surgical technique and speculated pathogenesis of recurrence after LT in like previously described BAC patients, bolt was done for our patient, and it may.
So what do you mean by pathogenesis of recurrence?
It specifically means contamination, literally.
But people don't understand.
Oh, here I try to write it out. To think it isn't enough. Maybe here, possible seeding of tumor cells from the recipient's lungs to the donor lungs at the time of implantation. Thus, it's important to avoid intraoperative contamination.
So I think so here's what I think. I think so here's the way I write discussion. And Richard, this is writing class 101. So the first paragraph of discussion, I always write what's unique about this paper. Why am I reporting this? Number one, this is the first case of, well, I wouldn't, I guess bilateral lung transplant utilizing cardiopulmonary
Pulmonary
bypass. So you write that, and also this is this is also such case that utilize minimum residual disease monitoring enabled by circulating tumor DNA. And this is a case where, but more importantly than those 2 points, this is a case where stage 4 bilateral lung cancer, it's, well, I guess it's an additional evidence that stage 4 bilateral lung disease without distant metastasis can be successfully treated with lung transplant.
Mhm.
In addition to the previous evidence existing, which are only a few.
Yeah, there have been.
Yeah,
Okay.
so those 3 points should be 1 paragraph.
Oh, okay.
So this is just like, why am I writing this?
Mhm.
Because number 1, lung cancer can be transplanted. Number 2, we could use ECMO, cardiopulmonary bypass,
True.
and then number 3, we can use MRD assay for these patients.
Right.
So you emphasize why
Great.
you wrote this in 1 paragraph.
Mhm.
Then you say first. I would not go to cardiopulmonary thing first because that's a technical issue.
Oh, okay.
People look at it, I interviewed with television station like an hour before I was in a
Interview.
interview with the television people. They asked me about Albert Curie's case. They were so curious, and they said, "Oh, lung cancer should be transplanted. Why is this a unique case?" So the lay people, they don't understand that lung cancer is a contraindication for transplant. All advanced cancers are contraindication for transplant because they know it's going to recur. You'd rather transplant someone without cancer.
Mm.
Okay. So why did you, the question is, number 1, why is IMA, invasive mucinous adenocarcinoma, a good candidate for lung transplant? what is the evidence out there? Or there are several evidence out there,
Mhm.
and this is their evidence, and this is what this is unique pathologic presentation of IMA. It's not every IMA, but it's subset that will only have bilateral involvement and no distant mets. And this is the data, and this is why we think it's good. That's first main idea, and you have supporting evidence from the literature in your case.
Okay.
Second paragraph right there. Third paragraph, you talk about cardiovascular, and then you cite our JAMA paper,
Right.
talked about our COVID-19 experience, utilizing the cardiopulmonary bypass, and with COVID destroyed lungs, it worked well. And you talk about the contamination theory. You cite our papers that we published, that this might limit these this bilateral transplant may limit contamination and may be a promising way to tackle circulating tumor cell contamination in the field of organ transplant.
Mhm.
That's your second paragraph. And then thirdly, and you say MRDSA can be applied not only applied in post-transplant surveillance setting, and this is what we've used, and this the Albert Curie's findings can be interpreted this way and that way. You know, you can talk about the details.
True.
So that's the structure that
Mhm.
is ideal and optimal. You can write about all these things without a structure, but I always think the best way to structure,
Mhm.
what's your point? And you have to say it in the order of importance,
Mhm.
clinical relevance.
Understood. Yeah.
I think the first paragraph you talk about ECMO, and that's too soon. And this, like, is this the most important thing? No, that's just a technical issue.
Got it.
Okay, let's go back.
Okay. So yeah, I think I can definitely make it more organized and well by organizing everything according to the importance. And so far I think I've focused too much on the MRDSA part. So I think you can look from this point. Here
Uh-huh.
I wrote about MRDSA.
Yeah, that's okay.
Mhm. So in our patients, surveillance of recurrence has been conducted with two different MRDSAs. First, the tumor-informed staining assay. I try to briefly introduce the Signatera,
Yeah.
and the plasma-only assay. I try to write about the Guardant.
Uh-huh.
In our case, a discrepancy between the two assays has been noted. Unlike tumor-informed MRDSA, plasma-only MRDSA revealed 4 genomic alterations. Maybe I can, yeah, and throughout his journey, like.
Okay.
But and in addition, none of the plasma-only MRD. I try to ask, may I ask, so none of the plasma-only MRD detected genomic alterations were concordant with the results of tissue-based NGS results. Is it correct? So I try to write about the
Or concordant. None were concordant.
concordant means like I try to write about it doesn't overlapping.
Yeah, I would just say that
Okay.
mutations found in the
Plasma
plasma
only.
did
Mhm.
not overlap. You know, none of the mutations overlapped with the mutations found from tissue-based S. So you have to be consistent. If you write tumor-informed,
Mhm.
just write tumor-informed.
Oh, so actually that's a good, or the point where I'm a little bit confused. So,
You have to be consistent.
okay, so here tumor-informed MRD assay, I
Yeah.
try to refer to Signatera, But
Yeah.
here, tissue-based NGS results, I try to refer to the Tempus. Because we also looked whether the mutations from Gardens is in the Altera results.
I see. Well, so it's found by, it's actually both, right?
Yeah,
Not overlap with Tempus
Both.
nor Altera,
that's true.
right? So, well, Signatera doesn't give you gene mutation, so yeah, you can argue both ways, bounded by both tissue-based NGS nor tumor-informed MRD.
Right. So here are 2 points. So 1.1 is Garden results was not aligned with Signatera results because Signatera doesn't detect any MRD. And also we can compare Garden results to the Tempus and Altera results.
Yeah,
Yeah,
that's fine.
okay. So the next part, there I try to structure it in this way that there are several explanations for this discrepancy. First, the alterations detected only by plasma-only MRD assay might originate from the other sources than his original lung cancer, like clonal hematopoiesis. I try to write about the clonal
Don't
hematopoiesis.
write like maybe such as including or including,
Got it.
and then you don't need comma.
Okay. So for the first part, I only dealt with clonal hematopoiesis. And as you recommended, I try to look up all the literature on the frequent mutations found in clonal hematopoiesis.
Mhm.
I didn't find any more mutations overlapping. So for this case, only TP53 and then NRAS is overlapping. So I listed 15 most frequently mutated genes in clonal hematopoiesis like this, and among them, TP53 and NRAS were also found in our patient. And yeah, as you said, cytotoxic chemo or radiotherapy can also contribute to the somatic mutations. So given his treatment history with various chemotherapeutic agents, maybe TP53 and NRAS could have originated from such clonal hematopoiesis.
Yeah, that's fine. What are the other genes that are not listed here?
Oh, it's TSC1 and then MAP3K.
Mhm.
And I found out that, so in the next paragraph, I try to write about more on the other sources. So in addition, cell-free DNA, do you think it's okay to bring up cell-free DNA word here? Because,
Yeah, it's fine.
okay. So it can be observed in other conditions, including aortic aneurysm, infections, autoimmune disease, post-organ transplant, post-traumas, AIDS, and asthma. Mechanistic insight
For
behind this.
AIDS, you should write out the acronym and then put in AIDS too.
Oh, okay.
I mean, I know it's widely used, you still do it.
Mm-hmm.
What about benign tumors?
Oh, actually, I try to find about the benign tumors such as colon adenoma, but
Yeah.
unfortunately, I've not found any direct, like,
Really?
yeah, that's what I found.
Because the conventional wisdom is colon polyp has APC mutation.
But APC isn't here, right? In the clonal hematoma. So I think, but I found some evidence about like leukemia or, you know, the CHIP, actually clonal hematopoiesis with insignificant, indeterminate potential.
Mhm.
I found some evidence that the correlation between the CHIP and then future risk of developing leukemia or hematological malignancy, but I've not yet found some evidence between the CHIP and the colon polyps. It's directly. So I've tried different search methods, but I've not come up with any article reporting that association.
Oh, okay.
Yeah, rather like there are many articles trying to figure out the correlation between the chip and other like infection or autoimmune disease. For example, yeah.
Yeah, I found the article that says the colon adenomas
Uh-huh.
are not prone to release DNA into
Oh, really?
circulation, are unlikely to be reliably detected with liquid biopsy, at least with the current technology.
Oh,
It's very interesting article.
interesting. Yeah, I even like try to put the two words like chip and adenoma, chip and benign tumors, but like not many articles were there.
That is really fascinating.
Yeah, so that's why I deleted, like, even though patient has underwent vigorous cancer screening, there might be some possibilities that we miss, like hidden cancer, but I deleted that part because I was not able to back up that statement.
Hmm.
Rather, like, yeah.
Because people talk about it and then
Yeah, maybe it's kind of misconception.
because we know it happens in the tumor in
Mhm.
adenoma.
Yeah, but I personally, I think having cancer cells in our blood means different from, having ctDNA having cancer in our body doesn't directly mean the possibilities that we can detect ctDNA in our blood, because there might be some cell lysis process.
Hmm.
Then that apoptosis, something like that, that could be like easily induced by inflammation or kind of immunologic event, not only just having a cancer. So maybe there might be some other necessary process. Or interestingly, like I might be wrong, but it may be not mean nothing, but like post-traumas can cause ctDNA release. So maybe for TSC1, it was only detected in our case, like very temporarily in between like the transplantation itself. So maybe it could be coming from just transplantation itself, maybe.
So there are multiple studies that reported adenomas had KRAS mutation, circulating DNA.
Really?
Yeah. So I'll forward it to you. Or you can look it up. This is the review. And it talks about benign cases. You see it here. Colorectal.
Oh, yeah.
So this one is,
Mhm.
if you go, so because it's a review paper, they cite papers that found adenomas with ctDNA, cfDNA.
Mhm.
So there are a few papers they mentioned. So
Oh, yeah, I'll definitely have a look at that.
yeah, so just cite those.
Okay.
I think it's rare, but it's possible. And I think you should cite that here.
Got it. Got it.
Okay.
I want to ask your opinion on this specific paragraph. I try to explain about MAP3K and TSC,
Hmm.
but I think it's too maybe.
Post-traumatic stress disorder. That's just very interesting. So you could be stressed out from your medical school exam, and then you can have this detected in your blood. Is it like a psychological thing?
Yeah, actually, they looked the patients with PTSD and they detected PTSD. So, oh, it was just the one paper, but that
Wow.
was the only paper.
What is the mechanism? Like,
Like when whether it's coming from like physical stress or psychological stress, our
Mhm.
body may be reacting to that kind of stress within like using similar mechanism, maybe inflammation, maybe I don't know. Do you think should I elaborate more on that mechanism here?
No,
I just
no, I think it's fine. I think this is fine.
You think this is fine?
Uh-huh.
So do you think can I keep this part as well?
Yeah.
This is not directly related to our patient, but it's still
Yeah, I think it's interesting. It's helping the increase
Oh,
neutrophils in response to multiple stimuli.
yeah. Okay.
Yeah.
So just for our information, MAP3K has been detected in PNH like patient, which is kind of immunologic disorder still.
Yeah.
And yeah. And secondly, I try to talk moving on from cell-free DNA. I try to move on to the clone like VAF. The biology of allele frequencies of clones may provide a clue for interpreting the discrepancy.
Okay.
So yeah, okay. So I write it cited the Charles Swanton's article like VAF of 0.1% corresponds
Uh-huh.
to the primary tumor of and therefore we suspect the mutations detected on plasma-only MRDSA in our patient do not stem from his original tumor itself, but from other sources, including clonal hematopoiesis. And given the specificity of the assay to the individual's tumor, the tumor-informed MRDSA may have more clinical significance than the plasma-only assay.
Hmm.
Do you think it's fair? Does it sound fair?
Specificity.
Maybe I should delete this part.
Yeah, I don't like the specificity. May have more clinical. I don't think you need that sentence. This is not to say one is better than the other. That's what
Okay.
it tries to convey. I think both has unique pros and cons.
Mm-hmm. Okay. Okay, we're almost there. So the last part, but I want to emphasize that we cannot like exclude the possibility that these mutations may actually originate from his tumor. It's a slight chance, but still. So in that case, I try to write about the immune editing possibilities in his body. So in that case, a low level of MRD detected in our patient may reflect the host protective role of the immune system. So both innate and adaptive immune systems are assumed to detect tumor cells and destroy them before they become clinically apparent.
And in the recent study, you can put in the parenthesis the name of the study, Japan Circulators, right? Was it?
Yeah, it's that study. Okay.
Yeah, so that people know what it is.
Yeah, I try to explain about that Japan Circulate study, especially our focus. So yeah. So I try to write about the facts and then try to explain about the mechanism. One explanation for this phenomenon is the immunity of patients keeping residual tumor. Oh, it's not readable.
Keeping residual tumors DNA shedding. Immunity of patient keeping.
It's not.
I don't like immunity. It's such a vague word.
Okay. Immune system, maybe?
So you said below detection level.
Yeah, because I don't feel comfortable to say that immunity like eliminate the tumor like at all, because we what if we cannot just detect the very small amount of cancer? But still, I think I can argue that immunity kind of hold the tumor from growing.
Well, you can say immune surveillance or immune surveillance may have played a role in clearing
Clearing, yeah.
circulating tumor DNA at
From
least
the
below the detectable threshold or something like that.
perfect. Yeah. Thank you. So I wrote like similarly, coming back to our case report, similarly in our patient, we hypothesized that immune editing something may keep the residual tumor cells in a dormant state, given no evidence of radiographic and clinical
I
really.
don't like the sentence immune.
Okay.
So this is all hypothetically.
Yes. Or maybe I can just delete the whole
So
sentence. Like,
similarly in our patient.
we can
So whether it's immune editing or surveillance, just pick one. I would maybe
okay.
want to do immune editing. Some people are not
Not
familiar
familiar with
editing.
okay.
So
Mm-hmm.
Robert Schreider's paper, we looked at it, right? So cite that paper, and immune editing is put his definition there and cite that. And then you say immune editing similarly in our patient, immune editing also may have played a role in terms of
Keeping or
it's like keeping his disease at bay, but that's more colloquial. So we would like to say keeping his disease under control, or keeping allowing his disease to be
controlled.
to be well
Okay, I'll
allowing
look it up.
for him to remain without radiographic or molecular evidence of recurrent disease.
Perfect.
Yeah. Okay.
Okay, thank you. And yeah, that's pretty all for the MRD assay discrepancy related. And because they don't require us to have a conclusion part, I try to summarize our case report's uniqueness and values in the last part.
Okay.
So we present the first utilization of Bolt, maybe I should be consistent here. Bolt using cardiopulmonary bypass for an IMA patient with no recurrence or organ rejection over 8 months. Our case is also unique in monitoring recurrence using both plasma-only and tumor-informed MRD assays, in addition to radiographic modalities and biopsy.
Okay.
Although serial MRD monitoring is warranted to, is it too wordy, like elucidate the discordant results of 2 assays, this study may provide an insight into the optimal utilization of Bolt for IMA patients, as well as prognostic values of MRD assays in disease surveillance.
That's fine.
Okay. So my understanding is I should make the first part of discussion into more
Yeah.
organized way, and then, okay,
Well, let's go to the title.
title.
Okay. What is the status of the abstract for this?
Status of this abstract? So curious case abstract is approved by the World Lung Conference.
Yeah, who's the first author for that?
EASL.
Okay. I think he's the second author.
Okay.
No, I'm saying for this article,
Uh-huh.
who contributed the more, I guess Iser did the abstract.
EASL did the abstract. For this abstract?
Yeah. No, I'm saying for the whole story.
For the whole story. Yeah, I refer to her abstract very much while I'm writing about the case presentation part.
Yeah.
And
So
also,
she started the project, right?
right.
And then she was the first or second author of, I think, of the whole project. So she initiated the project. So I think,
Okay.
so let's do this. Put her name
In front of,
after your name, because I think she initiated the project. And then put my name up front at the up front. And put Ankit Bharat's name at the end. Last author.
I'll check it again. Yeah.
And then
Other surgeons, do you think?
and then for the corresponding author, you can put asterisk my name and Ankit Bharat's name.
Okay, for corresponding author.
Yeah, there's such thing as co-corresponding author. And who else helped you with this? Is this all people who helped you?
Yeah, I think so. Maybe Minjung Kim. She was also.
But did she help you write this article?
Oh, I haven't reached out to her, so
Yeah.
yeah.
So Did Iser Kim help you write the article too?
She actually gave me a lot of comments, but writing part was mostly done by me, but but I refer her abstract very much. And also Junie helped me a lot writing this case presentation part as well.
Okay, so I guess she started the project. She is the main presenter for the abstract.
Mm-hmm,
She helped you along the way.
mm-hmm.
So you can put a different asterisk, my name, Shin Oh, and Iser Kim.
Okay, different. What? Okay,
Different
I'll.
asterisk,
Okay.
yeah. And then you could put equally contributed. Just write equal contribution. So that way, three of us can claim that this is a first author paper.
Got it. Yeah.
Okay.
Okay. And
Leah, make sure everybody, Juhi, Arnie, Liam, Sungmi, reads all the sentence, make sure there's no error. Every sentence reads well, there's no grammar errors.
okay.
Or if there's something that they read and they don't understand, then they have to tell you, because it will likely not be understood well by the reviewers.
Okay.
And this is a nice case report, will be a good educational experience for Richard as well. So Richard, why don't you read this and give us your feedback in medical writing and your fresh view, and whatever you don't get, you get, give feedback to Eugene, and like any proofreading you can do, and we will acknowledge Richard as like in the endorsement, like helped writing or something. We'll just add Richard in the endorsement.
Acknowledgement part.
Yeah,
Got it. So okay.
So because he's a transplant patient, he's consented to the tumor registry. So this is for Liam, like he consented to the tumor repository. So put that IRB, like endorsed by in the method. IRB.
Dr. Shay,
Yeah.
really sorry, but could you repeat that part again? Because we haven't heard together. So he was not on the.
Yeah. So he must have consented to the transplant repository protocol. So in the method, say he consented to the transplant, protocol approved by IRB. And then in the funding, whatever funding was approved for that tumor registry, we'll just acknowledge that funding, whatever Ankit Barak got, that from, because he consented to that protocol.
Okay.
And also in the discussion, I think you should say the protocol is we're planning to activate advanced lung cancer bilateral lung transplant study in our institution or something.
Could you recommend which part that would be the best part for that? Maybe, yeah, okay. Do you want me
I
to
think-
put
I
on?
think- I think it's in the very end. It's fine. 'cause
It's in the very end. Okay.
Yeah.
Just
So
one.
Liam, where are we with that? Did we submit that to IRB or where are we with that protocol?
For the double lung transplant?
Yeah. What are we waiting for something?
Halted, right?
Yeah, so the double, wait, let me,
Double lung, so we decide to add non-lung cancer.
right.
Yeah. we-
So we still have to redraft that
Oh,
because we wanted to add all the other cancers now, like,
Oh, yeah. So,
Yeah.
so that's our priority because we wanted to open it ASAP. That way, next time, and then once we IRB approves it, then we will be able to register it in the NCT, clinicaltrials.gov, and we will have our own NCT number. So wherever you are, people can refer it to go to that homepage and then call us and then register. So we want this to be ideally like an advertisement for that study. But I don't think so I think the study is in progress and then at the last minute, like even at the proof, if this gets accepted, we want to add that NCT number by the time we actually like publish this so that people know where to look up.
okay. So you mean that we can still proceed our submission process, and then
Yeah, because the review takes time.
that's true. That's true. So
Yeah,
don't
so
have
to
to wait
say
until-
the study will be activated and we don't have any reference yet. But once it's IRB approved and registered to the NCT,
Mhm.
then I think we should be able to submit this trial in progress to AACR, ASCO, wherever it is. We'll just keep presenting it as a trial in progress. That's the way to advertise trials and
Okay.
how people find out this trial.
So yeah, you mean that if this paper is accepted and then we got the NCT
Yeah.
number, do you
So Liam, work on the rationale. You could cite the liver transplant for the liver-only mets for colorectal. So the non-lung cancer approach, you can, for example, lung-only metastasis for sarcoma patients as an example that how prevalent that those are. So this, the whole point is respiratory failure is a valid concern, but if there is no other evidence of cancer outside that organ, transplant can still be considered. So that in a nutshell, in one paragraph, is all you need with those couple references. And then just send it for my approval, Ankit's approval, and then we'll submit to IRB and SRC. I think IRB and SRC. Well, SRC first, probably.
yeah, SRC first.
First, yeah.
So should we, well, just to clarify, so are we going to send this to Dr. Seth as well, or just you and Dr. Barat?
Just you. Yeah, just both of us.
Okay,
we'll try to send that hopefully today or tomorrow, by tomorrow.
Yeah. This is just one paragraph, and
Okay.
yeah.
so are we including sarcomas or?
So we're just gonna say non-lung cancer. That's it. It could be any tumor, and
Okay.
that's why we're not saying this is sarcoma trial. This could be, yeah. We're gonna make it really general because I think Dr. Steph is going to go for a different grant, and it's gonna take a lot of time. So yeah, I think this will be just like a general registry trial.
Okay,
Okay.
Um,
And
yeah, go on.
yes, okay. So Dr. Che, the last thing for this case reports is that we have our figure, but we have to make a table. And Arnie and I discussed about the table format yesterday. Could you have a look at it? Because there should be a lot of information regarding all the,
Okay, so is a patient received vinorelbine and gemcitabine together or separate?
oh,
I think separate. You have to look back on the chart.
got it,
It's separate that you have to separate, make it a separate.
got it.
All the other ones, I think EZH2,
Uh-huh.
didn't he get it as a trial?
He got it as a trial. But
Yeah,
still, during that time, Nivo EP was continued.
no, it was not.
Oh, sorry. Okay, so here, Nivo EP should be deleted, right?
Right, so it could be Nivo EP first, and then he might have gone to trial.
Okay. And then going back to Nivo EP and then with added Lenvima.
Yeah. So anyway, look at my chart. If you have questions, just ask me real time.
Okay, got it. Yeah. And you want me to do that?
No, it's up to you.
Oh, yeah, and these are the like CT, post-OP one, pre-OP one, pre-OP and post-OP. And then these are the surveillance.
So why did you do 3 months and 7 months? What is the difference?
Difference. The reason that I select 7 months is that this is the latest CT scan he has had so far. And then 3 months, I try to show the readers that I just want to cover his whole like recovery period. So I chose the middle one and then the latest one. But they're technically saying there's not much difference between 3 or 7 months. I just mentioned about this figure, like, oh, he has been still, he remains stable, like confirmed by CT scan done this time point. I just mentioned like that in the paragraph.
So only if there is a meaningful difference by the 2 scan makes sense to show the difference.
Okay.
Here's essentially same. I don't know. You can look at the reports again to see. Let's say more GGOs cleared up. Like
Oh, in that
for-
case, we can, okay.
Yeah, for CT scan, you see the left side. There's something that got lighter, or it's clearing up, and then these, because it's getting better, these look like inflammation or something. If there's any change you want to describe, then it makes sense. If you say 3 and 7 were essentially same, then I wonder if you really need to show it.
Got it.
You can just say they were same in the text. You don't have to show. If I have to pick, if they were essentially very similar, nothing meaningful to describe, I'm talking about the difference, then just to use 7th month.
Got it. Okay, so yeah, C is surveillance after transplantation. So we collected
Yeah.
MRTSA. Oh, maybe we should denote like here ctDNA, make it more like specific, like tumor.
Well, you can put that here, but you could just put that in the, because it's too long. You could put it in the
like a legend or
surveillance. Yeah, ctDNA assay were done using tissue-informed 16 gene mutation-based assay or something. This.
Okay, got it.
Yeah.
And then so these are this is the main figure, but we have to we try to make a table containing all the like his disease related information. Arnie, could you present that figure?
Yes.
Thank you.
Okay, so this is the picture that uh so there's a table, right, about the Tempest, Altera, and Gordon Signatera, and Eugene come out with the idea to make it more presentable. So this is like kind of the idea for make it like a timeline, pre-transplantation, post-transplantation, and what do you get from for the ctDNA. We make it different for tumor tissue and blood, and also from the factory, like blue one is for Tempest, orange for Gordon, yellow for Altera, and green for Signatera. Later, I think we should change the name of Tempest, Gordon, and Signatera, but I don't know. We want to present it first to you, whether like, do you think like, is it okay or any change of idea?
So first of all, from all the figures, this one included, no, you cannot put dates because it's a patient identifier. You know what I mean? Is there anything that you can search and find out who that patient is? That's a patient identifier, okay? So take out all the dates.
Yeah,
You
we
can
will
say,
we will change it
you know,
into
1 month before transplant, 1 month after transplant, things like that. You could do it, or you can put it weeks to be more specific. Fine.
okay.
And I don't like company name here or test name here. So you would have to use the generic tissue informed ctDNA assay. You pick a term and you have to be just consistent. Go for it.
Okay, we will use the generic term here as well.
For Tempest and Altera, you can say tissue NGS.
Tissue-based NGS, maybe?
No, it's not even based. It's a
Not
tissue
even- Okay,
NGS.
tissue NGS, okay.
Tissue based. So if you say tissue based, you were gonna think, is this a blood test? You know what I mean? You just say tissue, take out base from all your texts.
Let's skip as well, yeah.
So it's a tissue NGS. You can say 1, and Altera is tissue NGS 2, because they're basically the same thing. And you can describe tissue NGS 2 is you know, one that was used to create tissue-informed ctDNA assay in your method. You know what I mean?
Got it.
And that was, you know, Natera was the company, you know.
Yeah,
And then you could tissue-based 1, NGS2 was, you know, Tempest. You can put all that in method, but going forward, you just pick the name and be consistent with it.
okay, got it. So I'm not sure, so there can be a method part even in the case report? Do you think?
Yeah,
Okay,
you can put methods. There you describe all the essays. Yeah,
okay, I'll make it into that format, yeah.
But basically, do you okay with this picture or like the color or anything that make it more others like other ideas?
So pre and post. So I would use that as a timeline. So when was it done? I need to know. 1 month, 2 months. So when, just like the therapy, I need a arrow that tells me
Okay,
Oh,
because there's arrow, but I don't see different points.
yeah, we will mark the point, exact
Yeah.
point when the
For
test was done.
its
Yeah.
result. And you have to be consistent. One is RNA, one is and is this where is this going to be? Supplement?
Supplement, yeah.
I'll just be inconsistent. You functional mutation in BUS
Mhm.
and then RNA and then HRD and then TMB. I'll just try to be consistent in with your presentation for all boxes.
Got it. RNA.
Same thing. What's bold, what's not bold. I want you to make sure you're
Mhm.
consistent.
Okay. Okay. And do you think we need a separate table or figure showing this discrepancy between Signatera and Ardent, or do you think it would be okay? Because here, it has like Ardent results, but it's not that like prominent, right? The NRAS, it doesn't show like their changes according to the time point. The Ardent results, do you?
I don't understand what's your point.
So
I think I quite understand. So do you think like it doesn't need to change to give like the trademark of the company? Just put it just like we collect it into one block, one box. Like as an example, like this one
So
we separate.
this is a supplemental figure. So you need title, figure, and you have a legend. In the legend, you treat this, let's say if someone didn't read your article, you should be able to understand all this without anything. So you say NGS, so you explain everything in detail in the figure legend.
okay,
All the acronym, what does TMB stand for? What does HRD stand for? You have to write out all the acronyms.
Okay.
What does the NGS stand for? All that, yeah.
got it, got it.
Anything else?
Okay, I think we've covered pretty much for the case report itself, but how to stop? Can I just ask you to have a second look at the MRD essay?
Sure.
If you, based on the comments that you've given to me last week, I try to sort the MRD essay into different like categories. And just before starting analysis process, I just want to make it clear that I've coded it correctly. So here, based on the Singmi's data collection, I try to make an MRD tab into 3. So baseline MRD, there are only 6 patients who got MRD before starting curative treatment. And then for first MRD, so the thing is, like, I can kind of sort patients into 2 groups who has only one MRD, or the 2 MRD before the event happening. The event can be like progression or follow-up loss. So I try to make an MRD. I try to code MRD as if someone has MRD positive, then I'll put the I'll code the patients as 1, whether it can be a first or second MRD. And then for persistent MRD, I can only analyze patients who have more than 2 MRD assay, right? So, okay, then obviously, compared to the MRD group, persistent MRD analysis can be done only with a few, less patients, like only maybe 17, I think. Okay, yeah. I just want to make, so Seungmi and I like kind of messed up with this basic concept. So we considered all the MRD into like MRD, like, but we realized that we have to ignore the baseline MRD. So
Yeah, it's just the baseline. It's not MRD. MRD is only MRD. The word makes sense only if there's no evidence of cancer.
okay, got it. But for some reason, some patients has MRD assay results even before starting curative treatment. So yeah.
So that's not called MRD. That's called ctDNA assay.
Oh, only ctDNA, baseline ctDNA. Yeah.
Yeah.
Got it. We as of now, I'm gonna only consider this to, true MRD results, not baseline ctDNA. Okay. Yeah, in this case, I think I can reanalyze this with this data, this confirmed data, and then try to write about the manuscript or abstract as well.
Right.
So for this project, we'll definitely write the manuscript, but do you think, well, this abstract has already accepted in the word-long conference, so no need to be submitted to anywhere else, right?
World long. This is e-poster.
This is e-poster, yeah.
Oh, so when you guys put this in your resume or something, you don't have to write e-poster. You can write it as a poster because it's still a poster. ASCO has abstract only presentation, then you don't make poster for that. So it's different. It's still a poster presentation and they will still post it in a large screen. So your poster is being presented at the site and you have to make poster.
Okay.
And you can still attend with the poster. And then you make sure user's poster is converted to paper poster. Did you email them?
Yeah, I think she has emailed them yesterday, a few days.
Okay.
But I'll double check, yeah.
Just follow up.
Okay.
And then if you present it, you say presenter your name. It's important at your stage to be presenter on site because it tells us faculty members when we interview you guys for residency, anything, that we know you're very committed. I think that's really important. And that's something you can tell the interviewers, you've flown to Vienna, Austria, to present for the team. I think that tells a lot that you're really committed in presenting your work, committed to science, medicine. So they don't expect you to have like really good first author papers. A good poster with a lot of commitment is sometimes what we need to select good, candidates.
Got it. Got it.
So I just wanted to emphasize that.
Mhm.
Anything else?
There are many things I should cover as of now, but I will update you next week because yeah. For the
Okay.
cancer, yeah.
How about meta-analysis?
For cancer incidence,
Yeah.
yeah, I'm still processing that, and I think. So as you do, I really want to see the results, like, but as of now, I'm still in the process of selecting more articles. But so far, I've collected more than 8, so I can expect there's something to be presented. I'll try my best to present it within a few weeks. I mean, at least in 2 weeks. I think at least 2 weeks are needed for me to present that.
Okay. When is who's the next person to join our lab?
Next person to join our lab, 그
So
지상
we have Nimarta.
Marta. Oh,
So we have the undergraduate students coming in, and then the next doctor scheduled to join us is Nimarta, who is coming in mid-July. And Dr. Chisang will be joining us early 1st of September.
September. So I think Nimartha, she's joining what week? In how many weeks?
Oh, she still has 6 weeks. It's mid-July.
Mid-July. Okay, 6 weeks. Yeah. So I don't know if she has other commitment. We can invite her to join our lab meeting, and if she wants to start working remotely, then Eugene, you're more than welcome to work with her to divide and conquer. You can sort of
that's true. That's true.
let her do the citation, finding the right article, making tables. You can really have her being, involved in this meta-analysis, because I know you have so many things. So I think it's best that you work with someone.
That's true. That's true.
Yeah, and then same is true for Jisang. If he wants to start any project sooner before he physically joins the lab, you can ask Liam so that they because the 3 month, 6 month, whatever it is for Eugene, 6 months might be very short.
It is short. A lot of expectation.
Eugene handling many things together, Dr. Che.
Yeah. So we need and then the undergrads who are joining, making tables, figures, citations, and writing, sections, methods, whatever it is, divide and conquer. It's a teamwork. You'll get the due credit. And then the more projects you're involved, it just tells people that you're a team player. And it's been like that. And then, we want to be, as much inclusive as we can be. So ask them if they want to be involved, and feel free to assign works as a team lead.
Of course. Yeah, I will do that. I'll do that. Yeah.
Okay, anything else?
Not much. Yeah.
Oh, for Chuhi's project,
Oh yeah.
what about the meta-analysis for that one? Did you guys decide anything?
Yeah, we're collecting the data. We're trying to make a table because for her project, like we have to actually need each true positive, first negative, each that 4 numbers for doing meta-analysis for diagnostic accuracy analysis. But sometimes the paper only like reported sensitivity and specificity. So we have to convert that percentage into each number.
Huh?
So it takes a little bit longer than I expected, but yeah, we are collecting the data and our expectation is to finish the analysis by this week.
Hmm.
Yeah, so like because my experience was a little bit much like simpler version of meta-analysis. So here it took a while for me to understand and collect.
Okay. Once you have the first result, just
Mhm.
present it at next lab meeting. But if you have burning questions, always don't wait till Tuesday. Just ask real time and move on.
Okay, got it. Yeah.
Because I think that's also, time it has someone else will do before we do it. So
Oh, right. Got
yeah,
it.
there's no such article. So right now there seems to be no competitor, but who knows, right? So
Mhm.
so we'll do that. And in that, so did we have a well, I guess to follow up on that screening, I know Grail doesn't have research funds internal, but let's follow up with them if they have a research price. I don't think we have an answer, Liam. I think once, let's say we kind of, because I think their platform we want to use, and then maybe we Cancer Seek has all cancer. So maybe we can have a Cancer Seek team meeting, and then there's a for general screening, and then we could have such one with the EDGC. That's a Korean company, South Korea company. So Liam, you'll be the lead for this. So that's, and then Eugene definitely will, work with us. But because I think for Brazilian project, at least, and we'll see what the blood bank says, US blood bank says today, but I think it's if the company is interested, the Pridicin might be interested, but this could be, I would say, just like our MRD protocol, what I envision is we could use different companies, multiple different companies, because let's say each company says, I want 10 cc's. We'll just, when they donate blood, I think it's fine to draw 70 cc's. You know what I mean? That's nothing compared to the blood donation they're going to do. And then we can send it to 4 or 5 different companies. If they, let's say Cancer Seek wants to do it, we don't, if Grail, if we have to pay too much, let's not do it. You know what I mean? But we can actually ask them the price. Cancer Seek, let's see if they want to do it. Guardant has Reveal, but that's colorectal, but they might have all cancer, multi-cancer platform in place. So we ask them, do you want to participate? We'll ask, remember Jui's presentation, all the commercial players, we'll reach out to them and have a Zoom meeting. And if they're attending ASCO, we'll say, let's meet at the ASCO. It's a perfect time. We only have 1 week left. So let's try to send out those emails. So at least all the commercial, so they don't have to have like a commercially available product, but if they have a website and they say they have a research use only panel, and they are promoting their presence in ASCO, that's enough. That's enough for us to collaborate. So let's reach out to them. Whoever claims to be a future main player in this market of general population multi-cancer screening with blood tests. And you can start with the companies that Juhi presented. Let's reach out to them today. Let's set up a meeting at ASCO. If not, let's set up a follow-up Zoom meeting for them to discuss the blood donation, blood recipient screening of cancer. And I think Brazil group, they committed verbally. So let's see what we can do with our transplant patient. So we'll do that. It's just more like a preliminary commitment stage, but I think it just takes time. So let's move forward with those companies. So we have two projects, MRD and general high-risk group screening. And this, I think, would be like an academic study led by, because remember what's unique about these studies are all run by company. So you just have to, so remember there's like Genentech did that study of, what's it, maybe BMS. And the Predecessence panel was a really good one. Remember that call? And so if the third party does the test, they were able to do a better job. And which panel did, a better job in detecting cancer, right? So I think people would be interested to know the comparison. You can believe in companies' tests result, and it's not peer reviewed. It's just, it's like sometimes it's a black box. Every company claims they're the best one, but unless you get the same blood test from same patient and run it, you don't know. You actually don't know. So I think we're in a great position to do that. It will be a whole new career for you guys too. This is an untapped field. So let's just look at it. MRD is important for oncologist perspective, cancer patient perspective, but general patient screening, this is like everyone's problem, and I think it's important to know who has the best technology. In that case, it's important to include GRAIL as much as we can. So let's just follow up with them. Okay, anything else?
I actually have a couple things.
Yeah.
Yeah, just to add on to what we were saying before. So regarding the undergraduate students, I was able to reach out to IRB, and there is actually a way to get them IRB approved and get them officially on board with our research.
Okay, so as long as
So-
they do the CT training, they can be on board?
Yeah, so apparently
Okay.
as long as they do all the training and then get IRB approved, we can easily just add them to our study protocols as the study, study team members, and they will have full access to all the research that we're doing. So
Awesome.
I have,
Let's
yeah,
let's get them on board. I mean, anybody coming to my lab that could be like a basic training. Yeah.
yeah. So I just don't know about other people who are not NU or NM affiliated. So it worked well for the students because they already have like the net IDs and everything.
Yeah. So
Uh,
I think Richard, are you still on?
Yeah, I'm here.
Yeah. So have you ever had CITI training or?
Yeah, we have to do it for our class. Yeah.
Oh, really? Okay.
Yeah.
For your class. Okay. And then you guys have like access to Epic, and then you can read patient charts, right?
Yeah.
So so as long as you submit that certificate to Liam, yeah, we should be able to get you on our retrospective study protocol and yeah, everything required to get you on more like patient data collection or patient data analysis projects. Yeah, so medical students are fine. Yeah, we didn't know we could get undergrads on board too, but I'm glad to know. So undergrads who are committed in our lab, then let's get all of them on board for these chart review studies.
Yeah, yeah. So I've already sent out all the emails to the undergrad students who are currently at our lab and NU affiliated. I'm gonna have to follow up about the non-NU students, so we'll see what they say. But yeah, so I've sent the email out to Eileen, Sally, Hebian.
Who's
so far.
non-NU? Is that Suwon? Suwon is that
Yeah,
non-NU?
Suwon's non-NU, so I don't know if there's something else for her. But even if we can't get her Epic access, like there's plenty of things she can do when she's here. So,
Right. Yeah. Okay.
but I will follow up on that end.
Okay.
So, regarding the
Yeah. Also,
biorepository,
Sally, I don't know if she's doing CT training, so make sure she gets CT training too.
I already messaged her as well. The other question I had, can I share my screen?
Yeah.
Waiting for, yeah. So I got a response from Mary regarding the biorepository addendum that we're trying to do to their study. So there's just two questions that I thought I should run by you. The first being the questionnaires. So like we said, there's a really easy way for them to administer these questionnaires online through the REDCap program, I believe. And so we've decided to go ahead with the QOL 12 questionnaire that we were able to find because it's a more simpler and more kind of straightforward questionnaire. Question was, how and when do we want to administer them? Her question is, we could note that the first questionnaire will be collected at the time of enrollment. If enrolled prior to the lung transplant, which is our goal, what time frame should we aim to administer the questionnaire post-transplant? 1 year post-transplant or earlier? And we only want to administer this questionnaire twice, correct? Was her first question.
Yeah. I think 6 months is better.
6 months?
Yeah.
Okay. So
Yeah,
we'll do
and then
6
I mean,
months.
I don't think we can do it too many times. 6 months
Yeah.
at one time is good enough. Yeah, I think
Okay,
that's
so
good enough.
one's pre and one's post at 6 months.
Yeah.
Okay. So just wanted to clarify that. And then for number 3, well, I guess I'll just number 2, just to give you to fill you in. She says that's fine, that we can kind of leave it vague, and then just say no more than 70 mL of blood will be taken for now, and then we'll update it once we have the details. And then the third one is the question that I also wanted to ask you is about the blood collection. So currently their protocol notes that the blood may be taken at the time of transplant and at each standard of care visit to the lung transplant clinic. And at any of the bronchoscopies. Do these timeframes work for you? So these are slightly different to the biomarker timeframe that we have. The biomarker is pre-transplant and post-transplant. We don't do intraoperative.
Intraoperative, okay. Does it mention intraoperative in the lung protocol, in surgery protocol?
So that's what Mary is telling us. So it says currently we note that blood may be taken at the time of transplant and at each standard of care visit. They're asking if these timeframes work for us or if we need to change that.
So this language works, but then, you know, right before transplant happens in OR, you know, we can get the blood, we can still use that, you know, it still meets the pre-transplant. In that case, it's fine. And don't limit to transplant clinic. It could be any follow-up, future follow long, because in my clinic, if patient's there, it's it's fine to get it there. So the follow-up visit, just make it general so that it doesn't have to be surgery clinic, but medical oncology clinic. And then we don't need it too frequently. Let's say something happened and he comes for pneumothorax weekly. We don't draw. We will do our best to make it every 3-month interval. But these are the visits. So just make it applicable to. And then in the end, it's not like someone who doesn't know the protocol will only look at this language and do it. It will be up to you, Liam, or whoever the successor will be later, who knows the protocol and kind of plan out look at the patient schedule and then coordinate with the phlebotomist to get it done. So you'll still be in charge of when the blood draw will happen and consent, and it's not every surgery visits, and so just make sure the language covers the whole plan. In that sense, it's okay, but yeah, it will be upon a person who knows the program. Yeah.
Right. Okay. So basically, we're fine with this intraoperative language.
Yeah. Yeah,
Okay,
it's
so
like
I'll tell
it's
her-
not. It should be. It's maybe taken. So right. So it's fine.
Okay, so we'll just leave
Maybe
that
or
and then
maybe not.
just ask them to add on, medical oncology clinic visits too.
Yeah.
Okay. Yeah, then I think that's all. And I also think Dr. Davis just replied to that email sir, regarding the liquid biopsy. So I think we
Yeah.
can look at that together later. Or do you
Yeah.
want to do that now?
Oh yeah. Let's look at what he said.
So what Dr. Davis, Andrew Davis replied. I would just recommend adding a few sentences with the sample size and what the bar
Yeah.
looks like,
So
like
let's
what
look at the
figures.
article together and see what language we can use. Okay.
Okay.
So let's follow up on the Lexan paper too, with the Lexan people. Let's do that today, with Neil and as a lead scientist. Let's send out that email because this is one impressive case report. And this was this presented? What is it in the BioRx? Or not yet? Can't remember. Maybe not.
I'm not sure.
Maybe not. Okay, let's go over the statistics today after this meeting.
Okay.
Anything else?
And then that's it for now.
Okay. Next time, Liam, let's have present the timetable of students team and the patient or the care provider, interview dates, deadlines, and so we know our timeline for these.
Yeah, so agreed. So we're going to have a new schedule over the summer since we had a schedule for this semester, which is now finished.
Yeah.
But yeah, we'll have one for the summer when we get all the students and they're done with exams and graduations and stuff like that.
Yeah. Super.
Sounds
Sounds good. Anything else? From anyone? Before we wrap up? No? Eugene, you're good? All right. We will wrap up today. Oh, Tuesday, am I going to be in ESCO, right? Next Tuesday?
Right.
Yeah, so I think we will skip next week. I think we can do that meeting on Wednesday.
Mhm.
Wednesday. So my tumor board 7:30 to, let's say, it might run into 8:30 or 9. So so next week lab meeting is going to be either 8:30 or 9.
Okay. How about setting it at 9, just in case?
Yeah, let's
Or-
set up till 9 to 10, 1 hour. If we
Okay,
can start early, we will give you notice.
okay,
So we'll have brief update meeting on Wednesday, 9 to 10, next week only, because I'll be in ASCO Tuesday.
correct. I will announce that. Yeah,
All right.
thank you.
Talk to you guys later. Bye.